I'm Dr. Michael Miyazaki, and it's really good to be with you once more. Today, we're going to be talking about curing. Now, this is something I do every day. I cure all my restorations, whether they be direct restorations or indirect restorations. And I will tell you, for a long time, I think it was just because it was so simple, I never gave it a lot of thought. So today, we're going to be talking about the things you need to know when you cure your restorations. So if you cement everything and it's just self-curing cements, you probably don't need to sit through this. But if you ever use a curing light, I think we've got some tips you'll want to know about. So let's move ahead on with the program. There we go. So bonding. When I bond my restorations, I want to be sure that whatever I bond stays together. And I know that most of the materials that I use personally in my practice is light activated. So this was an example that I just thought of. A young patient comes in, about 14 years old, and was referred to us by another general dentist in another city. But this patient, you could see, broke tooth number 8, playing basketball, got elbowed. You've probably all seen accidents like this happen. And tooth number 8 was broken way down at the gum line. Now, at 14 years old, if this were your son, what would you want to do? So the patient went to an endodontist. The endodontist said, I don't want to do the root canal because if I do the root canal, this tooth is unrestorable. So the patient came to our office to have the tooth extracted. And I looked at this and I said, you know, if you were my son, I'd hate to extract this tooth because just, you know, all the aesthetic issues involved, but let's see what we could do. So I told the patient, I said, I think, first I told the patient, I wish I had the broken part of the tooth. And the patient, the adult with the patient said, you know what? We have it. I said, you have it? He goes, yeah, it's in the car. I said, okay, can you go get it? So the adult goes and gets that tooth. And when they bring it in, you can see on the lower left-hand side, it's this big chunk of tooth. It's basically the crown of the tooth. And I look at that and I go, wow, you know, maybe we can bond this back together. We don't have to do a crown. We don't have to extract the tooth. Let's see if we can bond these pieces back together. Now, this accident had occurred a couple days previous, and so there was a pulp exposure, and it had been exposed for a long time. So, you know, the idea of doing like some kind of pulp cap, I wasn't really too thrilled about because of the exposure had been there for so long. So I just said, tell you what, let's do the root canal. Then we will bond the pieces together. And then we'll do like a core buildup and a post down the center. And I think that'll hold everything together. And so that's what we did. We took the tooth and I did the root canal that you see on the upper right-hand side. And we bonded the two pieces together. And the immediate post-op you see on the lower right-hand side of the slide. I think it looked pretty good. We saw the patient 6 months later, still intact. That is the power of bonding. We're able to take pieces of the tooth and bond it back together. And it's very aesthetic. It's very biologically compatible. I think it's good. But we have our challenges. And so most of the restorations, the first restoration I did today was a class 2 on tooth number 14, upper left first molar. And when I got in there with my curing light, I was thinking about everything I was going to talk to all of you about today. And that is, we have to have curing lights that have the right wavelengths. Because when I first started to use a curing light, basically it was a blue light. And I didn't know a whole lot about it, but the photoinitiator that caused the polymerization of my composites and my resin-eluting cements at the time was just blue. It was camphorquinone, and it was in that blue wavelength. So if I had something that was blue, it was probably going to work. Today we have multiple wavelengths though, and I think a lot of clinicians don't really understand that we have multiple wavelengths that we need to have in our curing light in order to cure the modern day materials that might have multiple photoinitiators in it. We need to have a light that's intense enough to get through our materials. So if I'm doing a direct restoration like a composite, I may have to get down into the box 5 to 7 millimeters or maybe more. If I'm doing an indirect restoration, I have to get through the Emax, I have to get through the zirconia, and I need to be able to cure my cements through that thick material. I have to be sure that when I get my light back into the more posterior, typically areas of the mouth, that I can get the light directly over the box. And we'll talk about that. And we all know about polymerization shrinkage, and that's just the percentile by volume that the material will shrink as it cures. And so a lot of modern materials are around the 2% mark and maybe slightly below, maybe slightly above, but right around there. So what we've done in the past is we would place a little bit of material so the volume is smaller. We'll cure that so when we have the volumetric shrinkage, it doesn't have any of the ill effects that it could if we have a large volume and we have that 2% shrinkage. So those are some of the things we're going to talk about. Now, going back to the wavelengths. What you see here is just some common photoinitiators. And so you look at the wavelengths that they cure under: 420 to 450, 380 to 425, 350 to 490. It's very broad. And on the chart on the right-hand side, you see that we have a lot more that we have to cure today than just camphor-quinone. A lot of the photoinitiators went because camphor-quinone has kind of a yellow shade, and when our patients wanted bleached white composites, the manufacturers were looking for other types of photoinitiators that would not make the composite look yellow. So we have all these other different photoinitiators. And because the wavelength spectrum is so broad, today what's recommended is not a single wavelength curing light, but one that is a polywave. So this curing light that I have is the PinkWave. It's one of my favorite curing lights, and it has actually 4 wavelengths that we're going to talk about. But what I want you to understand is I've used a lot of different curing lights, and when I was teaching courses where we were traveling around a lot, I didn't want to be packing around 30 curing lights and, you know, the way the airlines are, and have to worry about them breaking. So we would buy cheap lights, and these cheap lights were $25 lights that we were probably came from overseas. And these lights, they emitted a blue light, and for a benchtop exercise, they would cure the composite enough. But even those lights, I could tell I wasn't getting that solid cure that I wanted in my practice. For a benchtop exercise on models, hey, it was fine. Doctors would understand the concept, but I would not use a light like that on my patients. The other issue that we have is what is the actual intensity of the light that our curing light is putting out. I want the strongest, brightest light I can get today, because when I have what we're talking about, either a deep prep or I have thick material I have to cure through, I want my light to be able to get in and cure. So we know that the further the light is away from the object, the intensity of that light decreases. So I want to be able to get my light close, and I want to have a really intense light there. So I want to get down into those deep boxes. So I need something that's very, very strong. And today we have, again, inexpensive curing lights that really don't have that intensity. And we have some really good value price lights that have that intensity. And that's the light that I want to use, something that has the intensity. Now, this is one of the things that up until a couple of years ago, I never really thought about a whole lot. And that is, we have our class 2 box, right? So we have let's say a mesial box. And when I bring my light in, we used to have the lights that had kind of long curved light guide, and that was more for anterior areas. They weren't really designed for posterior. But now I'm doing these on second molars, third molars, right? I need to get all the way back there. And if the shape of my light doesn't allow me to come in directly over that preparation, we get what we call shadows. So in this preparation, I've etched it. I put my light cured adhesive in these areas, and I thin it out, and I try to light cure that, but it doesn't hit the walls because those walls are in the shadows. I need to have a light that can get directly over that box form and cure all the walls. Now, another thing I worry about today is that shrinkage. I mentioned about that before, is that when I put my light over a box prep, the deep areas of the box are fairly deep. My light hits that area on the occlusal surface first, so that composite sets, shrinks, volumetric shrinkage again. And what's going to happen as the light penetrates further and further down into the box, well, then that composite too will cure and maybe shrink a little bit, but it hits the top first. So as the top area shrinks, what it's going to do is it's going to cause polymerization shrinkage that's going to pull that composite up towards the light, and we could create a micro gap down at the gingival floor. Now, if we get a micro gap at the gingival floor, so when you look at this, this is actually let me turn on my laser pointer so I could point this out to you. But this is a box form. It's a simulated box form in a resin block. And what happened here was the resin block had this class 2 prepped into it, and then it was filled in with composite and then cured from the occlusal surface to simulate what would happen in the patient's mouth. So up here at the occlusal surface, you know that this is going to cure first. It's going to shrink up. And then the light's going to penetrate a little deeper. It's going to shrink up. The light's going to penetrate a little deeper and shrink up. But because it shrinks further or first at the occlusal surface, and then as it works its way further down, it's going to cure, we end up oftentimes with what we call this micro gap. So right at the gingival floor, because the composite gets lifted away from that margin, we end up with a little micro gap there. And that micro gap's not good. I think about it. One of the things I love to eat is fresh bread, right? So you smell the yeast, and you punch it down, you let it rise again, and you put it in the oven, maybe paint some butter over the top because you really want to get that brownness to it. And you're not quite sure how long you should cook it. And you get it nice and crusty on the outside because you don't want to burn it. But then you take it out of the oven, you let it cool, and you crack it open, and it's still soft and doughy in the center. No, we don't want that. And we don't want our composite to be that way. We want our composite to be fully cured from top to bottom and all the way through. So let me ask you, when you think about where class 2 composites, especially where they fail, they rarely fail on the axial walls of our preparations, maybe occasionally on the occlusal surface because of wear and tear. But where I see a lot of times where I have to tell the patients, on the radiograph that you see over here on the right-hand side, is I'll get a PA or the bite wing, and I'll have to tell the patient, look at, we got some recurrent decay. And the patient says, what does that mean? Well, these teeth back here already have class 2, or they have fillings in them, and the fillings went down the sides of the teeth. But how often do you floss? And the patient says, I don't floss, right? Well, all that food and bacteria that gets trapped in between the teeth, down by the gum line, where the teeth touch, we call that the contact. It looks like there's some recurrent decay sneaking up underneath the restorations. The fillings are still there, but we're starting to get a cavity underneath there. So we've got to go in there, take out the old filling, take out the decay, and refill those teeth. Not a conversation that I like, but we see that over and over again, that recurrent decay. And that could be because of the micro gap that's created down there. It's kind of the weak link that we have in our restorative process, and we don't want to have that. And that's one of the reasons why in the previous video we talked about the bioactive 4,5-S5 glass that will neutralize the acidity down there and attract calcium phosphate and release fluoride so that we don't get that recurrent decay. But if you're not using that, what you'll see in your more traditional restorative products is like this, that in that interproximal area right at the gingival margin, we get that area of recurrent decay. And you're absolutely right. It could be because the patient not brushing and flossing that area, not being able to clean that area well, or maybe it could be the weak link in our placement process. So we need to have curing lights that have the proper wavelength, proper intensity, that prevent shadowing, and if they could decrease the shrinkage of our composites, that would be ideal. So what I want to do is introduce you to the PinkWave curing light and some of the guides. So the PinkWave light has 4 different wavelengths. To cure our UV photo initiators, I'm going to move my photo to the side. The CQ, we've got the red wavelength and near infrared. And what we find is the near infrared really helps to decrease the shrinkage stress placed on our composites. The purple and the blue are more or less just to cure our photoinitiators in our composite. And then the red happens to enhance all this so that we get better depth of cure and less polymerization shrinkage. So the power of this curing light is amazing. So the top line here, you see this is our PinkWave curing light. It starts out very high, and then here's our distance across the bottom. And you can see that at the 6 and 8 millimeter depth, we are still getting about 1,000 to 800 milliwatts of power. And when we get down to 10 millimeters, now we're still at what, about 475, 500. Still really good. But look at the power that we have and how it does decrease over the distance, but even at 5 millimeters deep, we've still got almost 1,000 milliwatts of power. So it gives me the confidence that when I use this light, that I'm going to be curing my materials well, even if I'm in the deep areas. Now, how do I deliver that power? We've got the boost mode. It's like the beast mode in the Cybertruck. So the boost mode is a 3-second cycle, puts out about a little over 1,700 milliwatts per centimeter squared of power. The ramp cure, some doctors like the ramp cure, that over a 20-second cycle gradually increases. And then it maxes out about a little over 1,500 milliwatts. The standard cure mode, which is the one that I use most often, is a 20-second cycle that tops out at about 1,500 milliwatts. And then there's a third mode that I can go to where it's just a white light, but that third mode is our transilluminator. So it is just a white light. And one of the things that's really cool about this light is if I go to one of the other modes, I'm just going to try to go to this is my standard mode, is that the light's actually pink. I know it's hard for you to see it, but it's actually a pink light. It's not a blue light. It's a pink light. And that's why it's called the PinkWave. It's a PinkWave curing light. And because the head is so slender, I can get it back there to a second molar or a third molar. And you can see this is a molar that I'm putting this PinkWave over, and it's just right over the top. So we don't have those shadows that we talked about. But with that PinkWave curing light, I can reach way back to the molars with this low profile, and it works really well. So I don't have to worry about the shadowing. Now, one of the amazing things, I mentioned this to you already, is that near infrared wavelength. Because of the near infrared wavelength, we get increased polymerization but decreased polymerization shrinkage. And with a decreased amount of shrinkage, that means we have less marginal staining, lower chance of micro leakage and secondary decay, as I was showing you in those clinical photos. I think a big part of this is if our composite's not pulling away from the tooth, there's less chance of our patients experience post-operative sensitivity. With the near infrared, we get better depth of cure, and that just means that the restorations are going to last longer, right? We're going to have a harder material. It's going to be more wear resistant, and we're going to have a better restoration. Now, I mentioned the light guides. These have just come out, so you may not even be aware that we have these for the PinkWave. But we have a tack tip, which takes this 12.1 millimeter lens and narrows it down to a 2.5 millimeter diameter tip, which you see on the far left over here. We have an interproximal diagnostic lens that is about 1 millimeter in diameter, and this is so we can transilluminate the tooth better and find those cracks or maybe even areas of decay. Then we have a contact curing ball, and this we can put into the contact because as I talk to different dentists, some dentists still have a hard time getting a nice tight interproximal contact. So let's just go through these really quick. These little guides slip right over the head of the PinkWave. If you've got it barrier sleeve over it, it'll go right over the top. This is looking for cracks, and I'm transilluminating the tooth, and I can see little cracks in the tooth, and it's very hard to get either video or photos of this, but even in this area you can see little cracks that you could not see well with just your eye. And so the transillumination works really well to illuminate parts of the tooth. Then, as I mentioned before, we have doctors that when they're doing the class 2s, they tell me that they have contacts that just are not as tight as they would like them to be. And usually I use like a sectional matrix, or in this case I'm just using kind of a Toffelmeyer, because it's probably one of the worst ones to use when you're trying to get tight contacts. And that's because when we tighten it up, what's it do is it shrinks up around the circumference of the tooth, but it pulls away from the adjacent tooth contact. And now if I fill that out with a composite, I'm probably going to have an open contact. So this is just showing using a little wedge down the gingival margin. Then what I do is I take my burnisher and I burnish that matrix up against the adjacent tooth contact to make it as tight as I can. Then typically I'll place my contacts in that little box and I'll cure that. But if you're getting contacts that are open, or where the patient comes back and says, hey, ever since you did that filling, I'm getting food that's impacting in between these two teeth, think about the way you placed it. With a Toffelmeyer type of matrix, it creates that gap. So what can you do? Well, we have the ball lens that we can put right over the top. And I'm just going to show you an example of how we would use this. We would go ahead and etch the tooth, do the primary adhesive, and then put some composite into the box, put that little ball into the box, push the matrix up against the adjacent tooth, and hit our curing so we could cure that composite and have a tight contact. Now, one of the things I'll do is I'll take that little ball curing tip and I'll put a little seam free. It's our composite wetting resin over the top just so it doesn't stick. Then I put a little composite into that box, and this is just on a typodont, so it's a little bit different, but to get the photo. But what I do is I put that ball into the composite, push it up against the adjacent tooth, cure it for 5 to 10 seconds, and then remove that curing tip from the material. And you can see how we're going to have a really nice tight contact because we actually push the matrix up against that adjacent contact. One of the things I want to point out though is just be really careful that when you put that the ball into your composite, that you don't sink it down too far, because if this little lip of composite gets over that ball and then you cure that, well, you're going to have a hard time getting the ball out of your composite. So again, put it into that box, push against the adjacent tooth, but try not to embed it in whatever the composite is that you have. So I'm just showing how then once you have that contact established, you can put more composite in there. And I have a different color composite just so you can see how that's beginning to fill that area up. So here we take our flowable composite, then I would gently place that ball into the composite, press it up against the adjacent contact so it's nice and tight. Don't embed it too deeply in there. You don't want to have it cure, the composite to cure around that ball and lock you in. But here you can see we can pull it out. Then we can, at this point, you could even take the matrix off and then pack the composite into your preparation. But now with this, we're going to get a very nice tight contact. We're not going to have a gap that your patient's going to come back and complain about. Now, one of the things that I really like is this tacking tip. It prevents movement of the restorations. If I'm doing a crown, I will wipe out the excess at let's say a buccolingual margin. I will tack that margin, which means we set it. But now, because we've taken that 12.1 millimeter lens and condensed it down to a 2.5 millimeter lens, I can partially set my resin luting cement on the margin. Now that restoration will not move. I can floss, I can do the cleanup of all my cement on the other areas of the tooth, and then I come in and I do my final cure. This makes your cleanup so much faster. So if you're not using a tacking tip, get one of these and give it a try, because I think you'll see that it makes it so much easier. Now here I am placing crowns on teeth 8 and 9, the 1-1 and the 2-1. I seat them down with my resin luting cement. All the cement comes out over the edges. Now if I came in with my PinkWave curing light with my 12 millimeter lens and I cured that, I would have a hard time cleaning up my composite. But what am I going to do is I'm going to come in with my 2.5 millimeter diameter lens. I'm going to wipe off the excess on that facial. I'm going to tack those crowns in at the gingival margin for 5 seconds. Now they're not going to move, so I don't have to worry about the crowns lifting up away and creating any kind of suction that's going to result in staining margins and sensitivity. I'm going to push the crowns down, wipe out the excess, tack and tack. And by doing that, we're tacking it in place. So this is just showing how when the crown on tooth number 8 or the 1-1 goes up, I'd wipe out that excess. I'd point my tacking tip up at about a 45-degree angle, so I only cure that gingival margin. I don't cure the interproximal, the lingual. And then I would tack it for 3 to 5 seconds, and now that restoration is not going to move. But all the cement on the lingual and interproximal is uncured. So I can go in there, I can floss, I can wipe off all that excess up. Then I take that tacking tip off, and I have my 12 millimeter lens that covers the whole. These are long centrals, 12 millimeter centrals, and I cure the whole crown for 20 seconds on the facial, 20 seconds on the facial of the right central, come back on lingual, do the same thing, and I am done. If you've got a smaller lens on your curing light, what you have to do is you have to do overlapping cures, right? So you do the gingival maybe for 20 seconds, the mid-body for 20 seconds, and maybe the incisal for 20 seconds, depending on how big your lens footprint is. But with this 12.1 millimeter lens, I can cover the occlusal of a molar, or the entire facial of these exceptionally long centrals. In 20 seconds and 20 seconds, I am cured. With the intensity of this light, I know I'm getting through the material and I'm going to have a good cure. So we did this and the patient had no problems. Worked really, really well. And that's why the intensity and the wavelengths and everything comes together. We don't have to worry so much about shadowing here, but having these different guides and decrease in polymerization stresses that we place on these restorations just makes everything so much better. So I go back. I know a curing light just seems so simple. We use one every day. Hopefully you picked up some tips. With the PinkWave, at least, we have about an 8.5 millimeter depth of cure. I had the transillumination. I had the lightweight. I've got the large lens that covers the entire occlusal surface or the entire facial surface of an anterior tooth. It is a high intensity output light. So some doctors will say, well, isn't there a lot of heat produced when you are using this light? So I had this on my thumb. I feel a little bit of warmth, but it's not uncomfortable at all. But because you don't have to have this lens right on top of the tooth, you can hold it a little bit away. There's this distance of forgiveness. So I can have it 4 millimeters off the tissue, 2 millimeters, 3 millimeters. If you are concerned, your assistant can blow some air on the tissue where you're curing it. But no worries, because the light's actually focusing about 6 millimeters away from the lens, down into the deep areas of the box. We've got the high intensity light. You're going to get a good cure. It's well collimated. That just means that you can have a high intensity light, and if it gets dispersed out, the intensity of the actual light that hits your restoration may not be that great. If you keep your light going down a tunnel, you keep that intensity, and that's what the lens of this PinkWave does. Again, it's very low heat emission. These wavelengths are not going to be absorbed by the pigmentation in the pulp, the blood, so you're not going to overheat the pulp. You're not going to kill a tooth. And I just love it. I'm going to move my head again. It's just this low profile. So if I need to get back to the molar, I can come straight over the tooth, over that box prep, and I'm not going to create any shadows. So this PinkWave curing light has everything that I want in a light. I would encourage you to check out your lights. I know we're coming up at the end of the year, and if you need lights, consider the PinkWave. It's got everything you want. It's got these little anti-rotational segments of the light, so it's not going to roll off your bracket table. It's got a power on switch on the top and a power on switch on the bottom. We've got the different modes. It's very easy to use, and because it's diagnostic, if you think a patient could have a crack in a tooth, just slip on the appropriate light guide, hit it in the transillumination mode, put it up to the tooth, and look for the cracks. This is a light that you need to have. So I hope you got something out of this. If you did and you enjoyed it, hit subscribe. I'd love to see you back again. And I want to say thank you very much for your time. We are building a great community. Thank you.